Dr. User is a graduate of the University of Michigan Medical School. He completed his residency in urology at Northwestern University and a fellowship in minimally invasive surgery at Northwestern University. Dr. User has a special interest in BPH, kidney stones, and minimally invasive vasectomy. Dr. User is board certified in urology by the American Board of Urology. And with all of that being said, I'll go ahead and turn it over to you, Dr. User.
Thanks, Brittany, and thanks to everybody who has taken the time to join us tonight. Hopefully we can learn something and maybe get you pointed in the right direction to treat your BPH if that's why you're here. So let's go ahead and get started. I think Brittany covered this. Please don't record. That's me. If you want to, and I think we'll go through this at the end, if you want to try to make an appointment or see where we're located, we'll make this available again at the end. But basically my offices are in Chicago Ridge and in Orland Park. And those are the phone numbers for the office practice. These are my interests. What we're going to cover tonight, we're going to briefly discuss the prostate in general. We're going to focus on BPH, and then we're going to particularly focus on the treatment options and what you can do to treat BPH. So let's talk about the prostate broadly. What is the prostate? Where's the prostate? It's a little gland. I don't know if this arrow works. Hopefully the arrow is working, but that right there is the prostate where my arrow is on. It's small normally, although not so much in our patient population. It's typically about the size of a walnut. It surrounds the urethra. So I always tell the patients that think of the urethra as like the core of the apple, and the prostate surrounds and squeezes the core of the apple. And so when we treat the prostate with procedures, we're sort of opening up the core. What does the prostate do? It creates the fluid that the sperm live in during ejaculation. That's all it does. It's kind of a troublesome organ, and that's all it does is it gives the sperm somewhere to live. The prostate grows to its normal adult size in a man in his early 20s, and then it keeps on going. It just continues to grow as long as you have testosterone flowing in your bloodstream, and it really starts to get going in your 40s and goes on from there. So there are different conditions that can affect the prostate, and primarily tonight we're going to focus on the enlarged prostate, or what people call BPH, which stands for benign prostatic hyperplasia, meaning just it's not cancer, it's just a lot of growth of those prostate cells. There's a lot of other conditions, but two of the sort of main ones are prostatitis, which is an infection or inflammation of the prostate, and then prostate cancer. Those are separate diseases, completely different. Some of the symptoms can overlap a little bit, and that's why Dr. Google doesn't do such a good job helping people figure out what they have. You really do need the help of a urologist to sort out why are you having these problems, what can you do about them. So let's focus in on the BPH, which we talked about. So like I mentioned before, it's also known as an enlarged prostate. There's a picture of it there of approximately kind of how big the prostate is. The reason that the BPH or the prostate growth is a problem is it squeezes down on the bladder. It causes what we call bladder outlet obstruction. It doesn't let the urine out, and the bladder starts to get thicker and more muscular to squeeze the urine past the blockage. And the bladder was not intended to be a thick muscular organ. The bladder is intended to be a soft, supple organ that can gently hold the urine, and when on demand can just gently squeeze. And if it becomes thick and muscular, it can't do those things, which is why the guys develop these LUTs, or lower urinary tract symptoms, of the frequent urination, urgent urination, those sorts of things. So is there overlap between BPH and prostate cancer? There can be, but they're separate diseases. BPH is not the same as prostate cancer. It is not caused by prostate cancer. The symptoms can be the same, because if there's a cancer in the prostate obviously can also grow and block. And so you can have both BPH and prostate cancer. We have blood tests, and PSA is one of the popular ones that we kind of use as a starting point. The PSA level does go up with both prostate cancer and BPH. And so it's important that you see one of us to sort it out. And we have all sorts of better ways of determining if the elevation of the PSA is due to BPH or is it due to prostate cancer, and some of that's based on age and symptoms. And we have more detailed 4K and ISO-PSA blood tests, as well as MRIs of the prostate that we do if we're suspicious that there's a cancer there. So here's a good picture of kind of what I was talking about before. This is a normal prostate, the normal looking bladder. The urine just flows through this channel and it's easy. There's not a lot of blockage there. One thing that's very important to understand is that the size of the prostate doesn't necessarily mean that there is either blockage or not blockage. So you can have a small prostate, but tight, and it can block the bladder off. So just because it's small doesn't mean that there's not blockage. The opposite is also true. If you have a very large prostate, that doesn't necessarily mean that there's blockage. I see guys with huge prostates and they're doing just fine. And so this is a nice graphic showing that here's the urine in the bladder and it can't get out. There's the blockage there, and it leads to all those symptoms that I had mentioned. So what are the symptoms? Well, the most common ones have to do with the blockage. It's hard to get the stream going. The flow is weak. You can't get it to turn on or turn off. It sprays. Worst case scenario is that you can't urinate at all. The scariest one is the bladder doesn't empty and the patients don't know it, which is why we do little ultrasounds in the office to make sure that's not happening. And then frequent urination. And that's one of the more common ones, whether it's during the day or at night or both. It's one of the hallmarks of BPH. So is this a common thing? Does it affect your life? Yeah, absolutely. And here are some of the stats. Many men suffer from BPH. 95% of the men have moderate symptoms, are unhappy. 49% of the men experience some sexual symptoms associated with it. 51% of the men say BPH interferes with an aspect of their life. And then they could obviously also impairs your routines and if you're a partner and your relationship as well. If you're waking up 8 times a night and your partner has to deal with you getting in and out of bed, obviously you're gonna interrupt the normal flow of things. So who can get BPH? Men, older men. It's most common prostate problem for men that are over the age of 50. By the time you're 60, 50% of the men have it. 90% of the men have it by the time you're 85. And when I say they have it, meaning they have some symptoms, it doesn't mean they necessarily have had, severe symptoms, but by the time you get to a certain age, pretty much everybody is dealing with it to some extent. In 2010, 14 million men were said to have had BPH and lower urinary tract symptoms. What are some of the risk factors? Obesity and lack of exercise may increase the risk of BPH, but this can happen to thin men, large men, men of all shapes and sizes. So how do we sort this out? I actually wanted to modify this a little bit, but a digital examination doesn't tell us that much. The reason we do a digital examination is just to get an overall sense of the prostate size. And then we feel for any nodules. Much more useful is we're checking whether you're emptying the bladder. We're doing an ultrasound. And then there's more advanced testing that we do. We can measure the flow of the urine in some special devices. We can also check the size of the prostate with an ultrasound. We sometimes have to look at the shape of the prostate with a little telescope, but those are further downstream. We don't necessarily do those things right off the bat. Self-evaluation. These are the two most common: the AUA symptom score, or the IPSS score. It's basically a questionnaire that says, you know, how many times you wake up at night, those sorts of things, and gives you a score, and you add up the score, and it gives you the same sense of, yes, it's a problem or it isn't. So let's talk about treatment. What do we do? So there's kind of three levels here. The first level of treatment are the just conservative things: behavior modification, you know, trying to cut down on your liquids in the evening, changing what you're eating in the evenings, maybe not so many fruits and vegetables after, say, 7 or 8 o'clock, moving those things to earlier in the day, watchful waiting. There are some bladder retraining exercises that honestly aren't all that helpful, but for sort of less bothersome symptoms, those do work to some extent. Then we have some first-line therapies, and these are just a few of them. Obviously, medication has been around for a long time, and the medications have improved. They used to cause a lot of nasty side effects. The guys would fall down, they would get real lightheaded. The side effects from those medications have come down, but there still are some side effects. And honestly, that is an area of some controversy. Some people think that the medications really shouldn't be kept, you know, being used for many, many years. But that's always usually where we start, at least to see if the medicines work. I like to do that just because it gives me a sense of, if you're better with the medicine, perhaps you don't like the medicine. But if you like it and it's working, then at least we know that the BPH is the underlying problem. We're going to focus primarily on this Rezūm water vapor therapy a little bit later. And that's one of the treatments, as well as implants. There's a few others. There's a microwave. There's a couple of newer procedures as well that, you know, have their positives, have their negatives. And again, you really need a urologist to help you sort out which of these is the best option. And then finally, we have the surgical procedures. And basically, you know, these things are creating an opening in the prostate. These things really create an opening in the prostate. And sometimes these are more appropriate if the prostate is really large, or if the shape of the prostate is such that these first-line therapies don't work. The old-fashioned way is to actually cut the prostate out. We can be done laparoscopically now. TURP, or what guys used to call the scraping procedure, works quite well. It certainly has some side effects, and it's done in an operating room under general anesthesia. The green light laser is kind of the modern man's TURP. It's essentially the same thing, using laser therapy. So one thing that I get questioned about a lot is guys spend a lot of money on these, you know, late night commercial supplements. They don't work. They've done long-term studies, meta-analysis. None of these supplements work. These supplements do not work, unfortunately. So there's not a lot of reason to spend money on those things. So watchful waiting, what is that? It's like I said, sort of the lifestyle modifications. BPH can have a waxing and waning course. It can sort of get better and then get worse a little bit. And if it continues to grow, obviously, then it might be time to actually go ahead and do something. But in the earliest phases, guys in their 50s, they're starting to wake up a little bit at night. You know, just adjusting things a little bit can be helpful with some of these behavioral modifications. What are the medications? There's two big families of medications. The first and the primary way is something called an alpha blocker. It's basically the prostate relaxer. It opens up the prostate and the bladder. It allows the urine to flow more freely. These work quite well. They work pretty quickly, usually within a few weeks. We know if we're in good shape. It can, as I mentioned before, cause some dizziness, lightheadedness when you stand up. There are some interactions. It can cause a little bit of fatigue in some patients. It causes nasal congestion. And then ejaculation issues is kind of one of the more annoying things that guys don't like. When you ejaculate, you still It still feels good, but nothing comes out, what we call a retrograde ejaculation. 5-alpha reductase inhibitors are an important tool. Basically what it does is it blocks the testosterone from turning into its more powerful cousin, the DHT, the dihydrotestosterone. These work quite well in very large prostates, but it takes a long time to shrink a prostate. It can take 6 to 12 months. What are some of the side effects? It can cause some erectile dysfunction. It can decrease your libido. It can decrease the amount of ejaculate fluid, and it can cause breast tenderness and breast enlargement also in a small percentage of men. So let's talk about this water vapor therapy, or the Rezūm therapy. That's something that we do in our office. It can be done as an outpatient in a clinic, but the great majority of these are being done in the office setting, which is quite nice, especially in this sort of COVID era we live in. It does not require general anesthesia. I do it in our office with some local anesthesia and some sedation. We have a nitrous machine, or the laughing gas, which works really well. There's no permanent implants. And we know that about 4.4% of the guys after around 5 years need to be retreated, but the other 95% do not. What are some of the side effects? Well, in the short run, you're gonna feel it. You know, there's no shortcuts around any of these procedures in the short run. Usually, depending on the size of your prostate, you may need a catheter for a few days. The urination may burn, it may be frequent. There's going to be some blood in the urine and the semen. Urinary tract infection is a possibility. Urgency is certainly pretty common in those first few weeks as you're recovering from the procedure. Here's a picture of sort of what the prostate looks like beforehand. There's some blockage there, and then here you can see what the prostate looks like after it's been treated. I'm going to just play this. They did a nice job with this video. I'm going to play it real quick for us.
Rezūm water vapor therapy is a non-surgical treatment for BPH. Rezūm uses the natural energy found in steam to shrink the prostate. In just seconds, this precise technology destroys enlarged prostate tissue while minimizing any effect on surrounding tissue. Rezūm is a potential alternative to drug therapy, permanent implants, and surgery. It preserves sexual and urinary functions, and it's clinically proven to safely and effectively reduce BPH symptoms. Potential side effects include painful urination, blood in the urine or semen, pelvic pain, and urinary frequency, retention, or urgency. The procedure is performed right in your doctor's office or outpatient center. You do not need general anesthesia for the procedure, and Rezūm therapy lets you quickly return to normal activities. Talk to your doctor about Rezūm if you're no longer comfortable with your BPH symptoms. Drug therapy isn't working for you. The side effects from drugs are impacting your quality of life, or you don't want to have surgery or get an implant.
All right, I think we got the point there. So, well, I want to watch that again. So this is a nice testimonial. This is a real patient that the Boston Scientific people talked into doing this. But I can tell you that in my own practice, I have patients all the time say, "Doctor, this was wonderful. If you ever need me to make a video or tell other patients, I would love to." And so 97% of the patients would recommend it, and some patients are very enthusiastic. Let's listen to this guy's story.
I found out that I had BPH. My symptoms were a slow stream, and I would wake up frequently in the middle of the night. I first heard of Rezūm when I was researching enlarged prostate and the procedures to repair it, to fix it. And Rezūm was one of them. The more I researched Rezūm, it was the latest and greatest technology, and I want to be part of new technology. I think technology is good. My experience with the Rezūm procedure was very good. After the procedure, I was a little worn, a little tired, and the next day I felt fairly good and was able to get up and get around.
Since Joe's Rezūm procedure, we're able to spend much more quality time together, fewer interruptions, and we're just happier as a couple. The Rezūm treatment has made a very big difference in our life.
All right. So is the Rezūm the only way to fix the problem? No, of course not. There's plenty of other options. There's a very popular, it's called the prostate urethral lift. It's basically the same idea in that it is done in the office. It's done the same way with sedation. It's a little bit different in that it's not destroying the prostate tissue. It's kind of moving the prostate tissue out of the way, compressing the prostate tissue to create that channel. So we do leave these little implants in there. It depends on what study you look at, but it does have a higher surgical retreatment rate in a number of the studies that have looked at it. Side effects, I would say the side effects are relatively similar in the short run. Painful, frequent urination, blood in the urine, pelvic pain, urgent urination. Occasionally, those little permanent implant, those clips, calcium can form on them, and you can get a little bit of a stone. So I would say the side effect profile is similar between the two. Now, there's a couple of other office-based procedures, but really they're minor players at this point, and there's special circumstances when they might be appropriate, and I'm not going to go into them in detail today, but depending on your situation, might be worth discussing some of the other more unusual procedures, like a microwave or something. When it comes to the surgical procedures, the green light is sort of the dominant treatment at this point, and it's essentially, like I said, the modern version of the TURP, that hollowing out of the procedure. And this can be more appropriate in patients with more advanced problems, more tissue, or patients that have had, say, one of the minimally invasive treatments and it just wasn't enough. That the prostate itself was the wrong size or the wrong shape, if it was too large, which is the primary thing. It is an outpatient procedure in that it's done at the hospital under general anesthesia. We knock you out for it. Again, it's a destructive technology. We're removing the tissue by using the laser to vaporize it. Very low surgical retreatment rates. I've got many patients that were done 10, 12, 14 years now and are still doing well. And so it's really a great treatment in terms of the durability. Side effects, it feels similar. You go home with the catheter. It's not fun for those first few days. It is, there's some pain with urination, burning, frequent urination, blood. Sometimes you're not able to urinate right away. Incontinence, we really don't see. That would be pretty unusual. Anytime you're using the laser in the prostate, you can form some scar tissue. Erectile dysfunction, you don't really see that so much, but the ejaculation, the retrograde ejaculation I mentioned, certainly is much more common with a procedure like this. I'd say probably in the 30 to 40% range, at least, with the laser therapy versus single digits with the office procedures like the steam, the Rezūm. So here, we'll play a quick video, just show us what this is. So this is the fiber that we use. This is our little lightsaber. It's it really does feel like you're in the Star Wars movie with these things. These lasers are quite powerful. It shoots out sideways from the laser fiber. This is what it looks like. We've got these laser machines we bring into the operating room. It isn't really showing us all that much. Here we go. So yeah, that's essentially what we're doing is we go in there with our little telescope. We put this little fiber out there, and then we just start melting away. And it's we've got a system that we use to go through the whole prostate to open things up. And this one, I think my apple analogy works quite well. It's we're going in there and taking out the core of the apple. And so the channel that the urine flows through isn't that tight, constricted passageway. It's a nice, big, broad passage. The urine can just fly through there. And so you can see here the graphic of just how the urine would come out afterwards. Let's see if there's anything else interesting that they're going to say. It doesn't look like it. That's the end of the animation. So TERP is the other option. And there are circumstances where I'll do this. And in fact, I'll do a combination of the green light laser with the TERP. The TERP it's a little bit bloodier. It's a little bit more difficult to get the patients home the same day. If you're doing a TERP, it's more of an old-fashioned procedure. They have improved on the technology. We used to do what's called monopolar TERP. Now we use what's called bipolar. It's a different form of electricity. It really does a nice job in controlling the bleeding compared to the old-fashioned, but still it can be significant. So sometimes we have to scrape out the middle lobe of the prostate, which is an unusual formation. And that's what the TERP is really nice for. And then the green light works great for the rest of the prostate. So side effects, again, anything you go in there and you're burning or melting or popping or pushing or stapling, you're going to have pain and burning. You could possibly get an infection. Incontinence is a little bit more common with this procedure, although still fairly uncommon. Erectile dysfunction is also fairly uncommon. The dry orgasm or retrograde ejaculation is much more common with this kind of a procedure. And then scar tissue formation or narrowing of the bladder neck, we definitely see that on occasion as well, but it's probably in the 5% range. Prostatectomy. Generally, when we say the word prostatectomy, we're talking about a cancer surgery. There are versions of the prostate surgery where we go in there and if you think of the prostate as like a grapefruit, if you're removing it for cancer, you're taking out the whole grapefruit. If you're removing just the BPH tissue, it's like you're removing all the fruit of the grapefruit, but leaving the rind behind. And so that's a pretty unusual surgery. Obviously, you're going to be in the hospital. It's a general anesthetic. It works great, but it's a big bloody mess. And even if it's done laparoscopically, the patients, are still in the hospital recovering from that for a little bit, and bleeding certainly can happen. Insurance coverage, yeah, all of these procedures are pretty well covered, but the insurance companies love to play games, and so, we have armies of people that go through all these things to make sure that it's covered. So let's just summarize. I think we've gone through this in pretty good detail. The treatment options for BPH, the enlarged prostate, is watchful waiting in the early phases, followed by most commonly medical therapy, the alpha blockers or the 5-alpha reductase inhibitors. Then we talk about the vapor therapy and the implant therapy. And then finally, the surgical procedures, kind of the last case scenario or special cases with really large prostates. So what's your next step? Consult with a urologist. Questions? And then let me just run through these references here.